For those who haven't met me, I'm Dennis Auckley. I'm one of the pulmonary sleep docs over in Metro, Sleep Center, and I've been here for quite a while. I was asked to talk about parasomnias today for you guys, and this is sort of a part of the boot camp. So it's a really sort of general overview of things. Many of these topics could be an hour lecture in of themselves. I'm sure we'll hear more about them as the year goes along. What's the story? See me coming in. And I'd really like to give a shout out to Dr. Carter, Dr. Posumar. Hugo used to be with us. He was at the clinic in, I think, UH at one point, and now is out in California. So here, I borrowed some slides from them and some videos. I actually gave this talk. I used to give this talk a long time ago, but I realized when I pulled my slides that it's been 14 years since I last did it. So I think the change just a little bit. Disclosures, I've written a couple of sections up to date, and then I am on the Sleep Medicine Test Writing Committee, so I can tell you guys already know. That's questions given during this talk, I'm obligated to do that. Results, I didn't put any questions in. And then I do have a couple other disclosures. So one, I'm a somnologist, but I'm not a neurologist, and I'm not a pediatrician, so some of these conditions I've rarely ever seen. So if there are neurologists on the call or pediatricians, I welcome them to comment in if they have any comments on some of these topics that were discussed. And then again, the talk is, because it's such a broad topic, I mean, there's disorders, so it's very hard to cram this into an hour. So we'll run past an hour. And so feel free, if people have obligations or knowing to jump off, I'll just keep going with that. Through as much as we can, as quickly as we can.
Dennis, just sorry, real quick. Will you be able to be a little bit closer to the mic? Yeah, thank you.
Is that better?
Oh, yeah, I think that would be better. Thank you.
Radio station. So besides the fact you guys obviously are going to be seeing these things clinically, and so you need to have you're probably in the course of your careers, because you're doing some sleep medicine, you're going to see these things for sure. And so you need to know about all these conditions, and how to evaluate them and how to treat them. But it also is on the test that you'll see. So if you guys, I don't know if you guys ever gone to the ABIM website to see the sleep medicine or the blueprint for the test. But it gives you a breakout of what sort of questions will be on the test. Parasomnia make up 7%, and you can break it down by actually specifically the classifications of non-REM and the other categories. So what are parasomnias in general? So just a brief overview here. So what the ICSD describes these as undesirable physical events or experiences occur during entry into sleep, within sleep, or during arousals from sleep. So these are the things that kind of go bump in the night. So there's a whole bunch of different behaviors and activities that can occur. And it comes to a very broad range of things, though, besides movement behaviors, emotions, perceptions, breathing, autonomic nervous system activation. And we think that these arise primarily from an overlap of the states. So you guys know about the 3 states of being. You're either awake, you're non-REM, or you're REM sleep. And generally, there's during stable times, there's with normal, your process C, your process S, they're nice homeostasis. They're usually fairly smooth transition between these states, and so most people don't have problems with these things. But because sleep states do oscillate, there can be some temporary instability, and so it's common that we see some of these things happen, and it's during that time of instability we can have state dissociation, so we can have features of both, say, awake and non-REM, or awake and REM sleep, and that's where the parasomnia is coming. So again, we like to think about things in the normal background of, and you guys have probably heard about this, you guys are neuroanatomy talk, right? And so, about the sleep-wake switch. So you're awake, you're asleep, kind of seesaw back and forth, you're in REM, you're in non-REM. But unfortunately, to delve in a little bit, we can just briefly review a little bit of neuroanatomy, not my forte, so we can talk briefly about some of the high points here related to that. So again, this sort of sleep-wake switch here. So sleep is a suppression of wakefulness. So you have certain nuclei, so the lateral area that becomes very active, as well as the TMN. And it's during this point here, where the neurons in the anterior hypothalamus release GABA, and those inhibit the wake promoting areas of the brain. And so that's how we tend to fall asleep. And so again, down here, when the VLPO and the median pontine nucleus, when those send out GABA inhibition of the wake promoting centers, that's how it goes off. And so you kind of get a seesaw of wake, sleep, so sleep, wake, sleep. So that's our current understanding of how this sort of works. Similar thing with REM and non-REM. So we have nuclei that are inhibiting processes of that occur during sleep. So when you take away some of this inhibition, then you have certain nuclei that are activated. This lateral, dorsal pediculopontine nucleus, and the other one here. If those send signals down to these nuclei here, which then send inhibitory signals. So this is during REM sleep that prevents you from actually acting out your dreams. So theologically, it makes sense. You wouldn't want to be doing this, right? Because it would be very harmful. Or, as you guys know, dream sleep, REM sleep is time of sort of reliving, recategorizing, cataloging our experiences during the daytime. So the brain's very active, and you're thinking about things, you're reliving experiences, and if we actually didn't have this REM sleep inhibition of motor activity, behavior disorder we'll come to later on in the talk. And then when you have REM off, you have other nuclei that become active, and it turns off those things. So during non-REM sleep, you can obviously become active. So again, there's these overlapping states between wake and REM. So this transition period, this is when the REM parasomnia is going to occur, wake and non-REM. This is when disorders of arousal can occur, so fatigue, arousal, sleepwalking, sleep talking are the main ones. Also includes sleep eating disorder. And just so you guys know, if you guys heard these names, Mahalo and Shank before. So these are really the fathers of parasomnias, particularly the REM-related parasomnias. So they're both at the University of Minnesota. Mark Mahalo passed away a few years ago. They started writing about this 40 years ago. Large number of publications. Claudio Schenk is still alive. I've referenced some of his work. I'll give you guys a reference after a very recent update on the work on disorders, parasomnias. But these guys have published far and away. And one of the other caveats with this and thing about this is very little in the way of randomized controlled trials for many of the treatments related to these disorders. But much of the recommendations come out of these guys' experience. So it's kind of consensus actually from these guys. The ones who have published the most on the largest case series and others. And other therapies. So you'll hear their name. So the complex nocturnal behaviors, you can actually think about this one way. So when we're evaluating patients with this, obviously history is extremely important. And one of the things that's very important is timing of the activities. Sometimes it can be, there's a lot of gray area. Sometimes there's things that are very distinct and clear in the history of how this sounds just like this, but there's a lot of overlap between the big areas, and as you think of the non-REM parasomnias, the REM parasomnias, there's overlap between those two, and you'll see from some of the videos, but also seizure activity, which is always the biggest thing that we worry about ruling out with these patients. But the timing of when these things occur, it can be critical in terms of helping to decide when this is happening. So the sleep-wake transition, so the disorders that happen here primarily can be seizures, so you're falling asleep and then waking up. When we get into deeper sleep, particularly M3, that's going to be when we're thinking about the non-REM disorders, and then REM sleep, which can happen later in the night. That can happen throughout the night, but particularly in the latter half of the night, activity happens during that time. So just understanding the timing or getting a good history about when these things actually occur can be helpful. And then a couple other things in the differential. So I already mentioned seizure, we'll come back to that in a second, but also sleep-related movement disorders. So sometimes these things can mimic sort of periodic limb movements or, restless leg and wake phenomenon, but bruxism, things like that. So parasomnias tend to be more complex. They're seemingly more purposeful and they're goal-oriented. So they're considered sort of automatisms. They're non-reflex acts without conscious volition is what's way it's been described, and we'll come to what are called the central pattern generators in a moment, which explains how some of these behaviors manifest. And I mentioned already that seizures is a big concern, particularly nocturnal frontal lobe epilepsy, SFLE. And again, you can distinguish this somewhat by timing, so that they tend to occur most commonly during the sleep-to-wake transitions, so 1 and 2, that time period. And then N3 is more going to be parasomnia. Seizures tend to be more brief. The parasomnia activities, while it can be relatively brief, they often go on for several minutes, and that's less common with seizures. None of these things are absolute. So. Clustering of events, so seizures tend to come in clusters, boom, 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 boom. The parasomnias are kind of more one-off things that kind of occur. And then posturing, so obviously with seizures, you'll see the typical sort of tonic posturing, and then the stereotypical behavior, so the behaviors tend to be rhythmic, repetitive behaviors, as opposed to the parasomnias that tend to be more complex and focus and sort of behaviors. And then recall, so patients with seizures may have a more lucid recall of what happened, particularly with this type of seizure, as opposed to some of the parasomnias. Some of the parasomnias, particularly REM parasomnias, patients often have recall. So I came across this as kind of interesting, this FLEP scale, which I hadn't heard of before, just while researching for this talk, about the frontal lobe epilepsy versus the parasomnias. And these are by and large, so this is just sort of history-driven way to try and determine our patients at risk for one or the other. And it goes through a lot of the things I just discussed. So in this study, what they did, a validation study, almost all these patients, they were actually almost all adults, and they were mostly men, interestingly. And they didn't, but most of the men had, when the final diagnosis made of non-REM parasomnia, a couple of patients that had RBD. But again, looking at age of onset, so and then they gave points to all these things, with the positive points being more in favor of seizure. The duration we talked about, and they broke it out into different time frames, clustering of the events, the timing of events when it happened, onset of sleep, the symptoms, which they asked a number of different things, or wide range complex behavior, et cetera. And you got points or subtractive points for these things. So negative points favor parasomnia, the positive points in favor of seizure. They had recall and then the vocalization, which this is a little early. My understanding of the vocalization is it's a very gray area between but they found that actually, patients that scored positive on these scales, all the patients that had seizures, their total point score was positive. Of course, for parasomnia is almost all in the negative category. So just kind of an interesting tool that could be utilized in clinic if you were interested to do this. Although the way they did the study, and they haven't seen much about this afterwards, 2 trained researchers both interviewed the patient. So parasomnia has become a disorder because it can have significant consequences for injury to the patient, injury to the bed partner, sleep disruption, which can then result in adverse consequences during the day, daytime fatigue, sleepiness, etc. So just like many of our other sleep disorders. Adverse health effects, so these things, because of they can lead to sleep deprivation, which a lot of consequences of that. They can lead to metabolic disturbances, and for some of them, depending on the particular behavior, that can end up affecting things like diabetes, etc. And then there's psychosocial effects with this as well. So it actually can be a source of stress for patients, be a source of stress in a relationship, sleeping in the bedroom at times, things like that. So there's a lot of problems associated with the parasomnia. So, you heard about, it hasn't been in the news as much these days, but back, 20, 25 years ago, and actually, Mahalo and Shanks started as a side business, sort of a sleep forensic consulting business. So there's a number of high-profile cases in the 1990s and early 2000s about patients, actually injuring or murdering people, and whether these were actually parasomnias or not. So I think that current sleeper was just a cover-up, and so they actually, because people didn't know that much about these things, they actually formed this side business to consult legally to help sort of tease these things out. There's a couple of famous cases which look at these things. One from the 90s, that's not really exact detail, that the guy murdered his wife and different But anyway, this was a movie, someone made a horror movie about parasomnia. A woman has some parasomnia where she's sleeping most of the time, our behaviors, and there's some guy that can control her. So it's in the mainstream media as well. So as I mentioned, there's a large number of parasomnias, which is why it's hard to do all this in a 1 hour time frame. So there's a non-REM ones. We touched on most of these, and then sleep-related eating disorder is also now included in this grouping. So it's thought to be really kind of a confusional arousal subvariant. And then the REM-related ones, which primarily REM behavior disorders, when you're going to be most concerned about, hear the most about in the current isolated sleep paralysis and nightmare. And then the other ones, we'll touch on these towards the end of the talk: exploding heads, sleep-related hallucinations, and sleep-related enuresis. We're not going to talk about the parasomnia, do these other things. These are things that will manifest or look like one of these other sleep disorders, but it's due to a specific medical disorder or medication or substance abuse. So in terms of the disorders of arousal, so again, these four. This is a survey study done back in the 1990s. It'd be interesting to repeat this now. So this was just based on patients' self-description of what happened during sleep. And it was mostly adults. So this was 5,000 people in the UK, 15 years and older. But kind of surprising, because for a long time it was thought that most of these disorders of arousal happen in kids. And it's true, so that most of them do happen in kids. But a surprisingly high number of adults. So 2 to 4% reported some of these behaviors going on into adulthood. Some have adult onset of these behaviors, which is not super common, but can occur. And in that situation, it's very important to make sure what's going on instead of driving, not a manifestation of something else. These numbers compared to what's sort of generally thrown out from other studies in kids, a confusion arousal, sleepwalking for about 15% of kids, whereas night terrors can occur about 17% for sleep terrors. So what's thought to happen with the disorders of arousal is that certain areas of the brain are still deactivated with sleep, and in other areas become activated, particularly deeper parts of the brain, from the brain stem or what becomes activated. And so the basic drive states can emerge, and these things can be pathological. So these include things like eating, aggression, and it's mostly sort of a defensive posture aggression. It's not actually going out, so as opposed to REM behavior disorder, which I'll talk about later. This is more sort of defensive, but also sort of walking, eating, and sexual behavior, all things that are sort of considered basic drive states that can emerge from disorders of arousal. It's thought that this is related to these central pattern generators, which I will confess I didn't know a ton about, but these are all something that we possess that are genetically determined or learned behaviors or neural circuits with our deeper brainstem. They code for all the self-sustained behaviors of survival, which includes all these behaviors that I just talked about that manifest on parasomnia. So these areas become awake or activated during disorders of arousal, whereas the cortex is generally still asleep. And so that's where you see these manifestations that take place. So this is from Dr. Abaddon, courtesy of John Carter. But again, looking at these central pontine generators, they're located throughout the central nervous system, including the spinal cord, which is where it's located for locomotion. So again, a lot of these are kind of just sort of repetitive day-to-day behaviors that we do that you don't think about consciously. And so there's these central pontine generators, and most of the time they're suppressed, and they're suppressed during sleep. But if you have something that awakens these areas during sleep, it can lead to these problems with parasomnia. And apparently also some of the manifestations can include seizures. So again, that nocturnal frontal lobe epilepsy. And that same group I talked about that developed that flex scale, they also looked at video PSG. So if there's concern, so for most of these disorders of arousal, PSG is not necessary, particularly in children. If there's other things that are seen somewhat atypical, or you're concerned about a secondary process driving it, it's not unreasonable to think about doing it. It's not part of the diagnostic criteria. But they did video PSG on these patients, so they determined for sure whether these patients had parasomnia or frontal lobe seizures. And they found that looking at the video EEG, and then this game sort of goes back to history, there's some things that can clearly help differentiate these patients. So they were correctly able to identify 94% of the events in 120 different patients. And 100% of the parasomnia is actually identified by just these 3 simple things. So was the patient fully arousable at the end of the episode? So that's question number one. If they weren't, then did they have sort of the tonic or dystonic posturing? And if they didn't, then that would fit into a parasomnia. If they did, it would fit into a seizure or something. Sort of thing. And that's a seizure, not parasomnia. Now this is the final diagnosis was made off the full issue would be. If it did have a discrete offset, then they asked, did the patient remain prone or supine? So if they did, most of these patients had seizures. If not, it's parasomnia, so they got up and ambulated. So just sort of these simple three things. But again, obviously, if you're doing the PSG with the EEG, you're going to be able to hopefully get a final diagnosis. So these disorders of arousal, they have three common fundamental features. There is a strong genetic familial pattern. So risk if you have a primary family member goes up tenfold. So if one of your parents is a sleepwalker, very high risk is already a sleepwalker. There's a high rate of this HLA positivity. I don't know exactly what this codes for. I couldn't find this, but there's also polymorphisms on this particular gene. This 20q12 and 13, which there's a number of hinted genes in this area, but one of them is adenosine deaminase. So you guys know about adenosine and how it's as it builds up, you become prone to sleep, and this actually breaks it down. And so it's thought that postulated that potentially that the polymorphism here could cause interruption in a slow wave sleep with the adenosine being broken down. And then in terms of the pathophysiologies of partial arousals, they come from deep sleep. And then they all are usually precipitated by common things such as sleep deprivation and then certain stressors. So particularly common things, so sleep deprivation in itself. So you guys know about rebound sleep, you have rebound slow wave sleep, rebound REM sleep. So you have rebound slow wave sleep, that can be a big chunk of slow wave sleep. And then particularly if that is interrupted by something else, that can be a precipitating factor. If the cortical arousals are impaired, so particularly like the classic ambient-induced parasomnia, stimulus sort of arousal, and then things that fragment sleep, so underlying other conditions like sleep apnea and loneliness and stress can interrupt slow wave sleep, causes sort of that dissociative state where you transition between wake and sleep, coming out of slow wave sleep, and that can lead to these problems. So generally, these are not, so the non-REM parasomnias are not associated with psych disorders. And usually they're not, most of the time they're not associated with neuropathology or brain injury. They can be, but it's not common. So most of the time these are benign conditions that just happen to be probably part of physiology. Most patients don't have cognitive functioning during this time. So if you try to wake them during this time, they're not going to be able to, wake up like they would if they have parasomnias. They are usually associated with amnesia, so they're not aware of this. And so things that can fragment sleep, obviously, touching them, noise, other stimuli can trigger these things. And then they can't overlap. You'll see some patients that have multiple different disorders of arousal. Fusion arousals and sleepwalking, and sleep errors. So in general, this is just for the broad category of all these things. So the disorders, what the ICSD has is that they need to have a lot of things we already talked about. So recurring episodes of incomplete awakening from sleep, inappropriate or absent responsiveness if you try to intervene. So you got to try to the story, like trying to redirect the sleepwalker. That may actually cause more problems. So patients may get, so we talked about that central content generator with the aggressiveness being a defensive posture. They may actually start to push you away and defensive. They're not really doing this, but it's just part of the underlying physiology. They don't have recall of dreams, so it's very limited visual scene. They don't have recall of the episode. It's not better explained. And again, first third of the night, and then they continue to be confused or disoriented for some time after the episode. This is not, this also obviously gives you a post-ictal state from a seizure, so you always have to be cautious. Thinking about that as differential. So I learned a word. This is a slide from Dr. Carter. He has this in here a couple of times. To hear what semiology, what semiology is. Huh? Nothing to do with monkeys.
Oh, there you go.
Just sign of something. So behavioral signs. So in a confusional arousal, they're awoken. So this is looking at minutes on the x-axis, and the y-axis is the state of confusional arousal. So it's just confusional arousal. They wake up, and they last for several minutes and dissipate. This can turn into sleepwalking if they cross that threshold and they get out of bed, and that again can persist for several minutes. Sleep terror is the whole level above that. That tends to be shorter in duration. And then you can have mixed episodes where they can do all these things like we talked about earlier, and they can occur throughout the night, although again, they typically don't cluster like a seizure, so you don't have back-to-back episodes. They will have one, they go back to sleep for a while. If they have one,
I find it interesting to see church from sleepwalking. It just seems like it takes a lot more.
yeah, so I don't know, I suppose you could, I don't know, this is their approach to this, and I don't know if it's a true like hierarchy versus if you could lay them out next to each other. But sleep terror is one differentiating thing. We'll come to this, is that there's a lot of autonomic activation, which you don't usually get with any other problem. So we'll get into the first one here, confusional arousal. So this is progressive sitting up in bed, verbal confusion, plus behavior disorientation. If they get out of bed, this is going to be sleepwalking, not just confusional arousal. So again, there can be some overlap with these two things. They can sound pretty similar. The big distinction is that they don't get out of bed with confusional arousal. So again, slow wave sleep, sudden arousal, mumbled speech, disoriented, inappropriate behavior. They're a mess for the event. They may actually go back to sleep very quickly, and then once they hit N3 sleep again, it can recur. So this is a video one. So it's also known as in adults, particularly sleep drunkenness or sleep inertia. So this can happen particularly following naps. So you guys probably heard about this. In terms of napping, when we recommend naps, we want to do relatively brief naps, like 20, 30 minutes, right? The big risk with the longer nap is like nap for an hour and a half, and then you go into sleep, and then you can have sleep inertia, sleep drunkenness. And so if it's not important that you have that, or you have that, it's not a big deal. Let's say if you're on call, or you have to get up and go drive or something like that. So there's been studies looking at this and showing people have impaired function pretty often for 20 minutes following the arousal from enter sleep. So this is a video of someone on the couch. So it's kind of mumbling, sort of nonsense. And the other person's trying to clarify what he's saying. So that's what it might look like in an adult. So the criteria from the ICSD for this are that you got to meet all those criteria we talked about for non-REM already, those 5 areas, plus they have mental confusion or confused behavior when the patient is in bed, and there's no terror ambulation. So to differentiate from those two things. And then they don't have the autonomic response, which you'll see with sleep terrors. So, but in that differential, obviously, is going to be sleep terror, sleepwalking, REM behavior disorder, and partial complex seizures, particularly the frontal lobe seizures we talked about. And as I mentioned, these patients typically don't have a lot of psychopathology, but there is some data suggesting that there is some overlap, although it's not really clear that there's any cause and effect with some of these things, especially anxiety. And if it is, which way it might be going. There is a minority which will have sleep apnea, which can be contributing factors, or facilitating factor for these things. That's why you always want to take a good history. Again, like I said, diagnostic criteria does not include sleep studies for these patients. But if you're suspicious something else is going on, if there's other things that seem atypical, you're concerned there could be a seizure underlying this, you're concerned there could have sleep apnea based on the history, then a PSG would be reasonable. So the episodes are usually 30 seconds to 5 minutes. We talked about a lot of precipitating factors, so things that either deepen sleep or fragment sleep. So sleep deprivation, shift work, alcohol, medications, forced awakenings, sleep apnea, movements. And we'll talk about briefly. So one subset of this, an adult variant, is this condition called Parasomnia. Have you guys heard about that? A little bit? No. Yeah, so it's thought to be pretty rare, but this is sleep-related abnormal sexual behaviors. So again, semiology, variable signs of this. I think in my career, I've seen one patient with this who came in with his wife. There weren't any issues, but there can be big time issues with this. So like I said, it's pretty rare. Most of these patients do have some sort of family history of confusional arousals or sleepwalking. You generally do want to do a sleep study in these patients because it also can have potential legal ramifications. So the behaviors that these patients experience, so it can be like very forced or violent masturbation. It can be trying to initiate sex with their bed partner, obviously without consent, or reports of trying to initiate sex with anyone that's around. So getting up out of bed and actually kind of do this. So there have been case reports of people doing this with minors and things like that. Most of these are men, the majority, but not all of them are. And they think it's probably underreported in women. But if you go to this MacArthur Research Network, it doesn't really talk so much about this condition. It says it's pretty uncommon, but again, it can have medical legal ramifications and implications, and there's certainly a case I've gone to court related to this. That legal site sort of talks about things that might imply guilt, and a person has an intent to be conscious of what they're doing, sort of that sort of stuff. So treatment of this condition is generally to optimize the sleep hygiene, manage anxiety, stress. Safety should also be part of this thing. Something that's not controlled that may be part of sleeping in rooms. If you do identify any precipitating sleep disorders, so those should be treated. Clonazepam reportedly works for it recently, no randomized controlled trials. So it'd probably be impossible to do because the numbers are not that high. So in general, for the broad category confusional arousals, again, you don't need a sleep study. Treatment is often not indicated, other than just sort of there's a particular for kids, reassurance, good sleep hygiene, avoid sleep deprivation, regular sleep schedule. There can be what are called anticipatory awakening. So this can have is behavior used in pediatrics. So this is every night, 1 o'clock or 12:30 when the kid gets in their so asleep, they're waking up and doing this thing. You can go in and wake them up like 15, 20 minutes before sort of that anticipated time. Reportedly, that sort of helps suppress the number of events that can occur. And then if they do have a comorbid sleep disorders, again, you should do a good sleep history, look for these things, but you don't need to be testing unless you're suspecting anything going on. So this is that reference. So Irfan's the first author, Schenk is the second author on this. It's give us free online if you guys want. I can send this around. This journal, Therapeutics, just came out last year, but it's a review of the disorders of arousal, non-REM sleep. And they talk about, they have a nice box there on treatments. Again, there's no good randomized controlled data. This is kind of their own experience. So what they reference in here for using clonazepam and TCA is basically a case series of therapy. And avoiding drugs that may enhance those stories. The hypnosis, I'm not sure, but I think that's probably the indication. They list that in there for all the disorders of arousal. So you try hypnosis. I have no experience with that. I haven't tried it. I'm looking at what it says in the group. So sleepwalking or somnambulism. So this is pretty much similar to confusional arousal, other than the patients get out of bed. It can range from simple, non-goal-oriented behavior to more complex, and again, violent and appropriate agitated behavior. So you can see how this can be sometimes difficult to distinguish between REM behavior disorder, depending on what exactly they're doing. So getting the history is very important, and then getting, and I'll show you a video here, because I just saw this video on, I think, RBD. But the history of having bed partners video the patient. And obviously, if you are concerned about that, then you will want to get a PS treatment. So again, first third of the night, these can last several minutes, usually less than 15. The patient may appear awake, they may be eyes open when they're doing this, obviously, but they're usually confused, amnestic, either not responsive or they may get defensive if you try to interrupt them. These episodes tend to end spontaneously, and tend to get back into bed and go back to sleep. Although there is a risk for injury, certainly there's plenty of reports. I know people have seen these patients, I've had patients going down the stairs, going out of the house, particularly well documented with Ambien, getting in the car and driving, none of this while they're conscious of what's happening. Again, very strong genetic components. We talked about probably 15-7% of kids, peak age around 12, about 4% of adults. And there's some early data suggesting it could be associated with some psychopathology, but it's thought again that this is not a tight association with cause and effect, and there hasn't been a lot of data supporting that. That's mostly really related to more adult, not kids. So this is a young woman who had recurrent sleepwalking. She reported to the tech doing the study that she had a vague dream recall. But this came out of N3 sleep. Let's see what she does here. So she didn't actually get out of bed and sleepwalk this episode. But this was kind of a more complex intentional behavior that she did. And that you wouldn't know, this could be RBD. We'll talk about that in more detail. Patients are often acting out, doing something in the dream because you're trying to avoid something. And usually they'll have very strong, RBD will have very strong dream recall. But the PSG documented this came out of SFBC, so that'll be consistent with that. So again, the diagnostic criteria, meeting all the non-REM criteria, plus the get out of bed or other complex behavior that. Similar differential, sleep terrors, complex partial seizures. Particularly there is one called episodic nocturnal wandering, so they can be a seizure. So if we have any suspicion of anything unusual about, particularly don't think about sleep study, full EEG. RBD, like we talked about, sleep apnea can rarely manifest in sort of behaviors like this. Nocturnal eating disorder, malingering, all part of the differential. Similar sort of list of precipitating factors, including a number of medications, kind of a disparate group here. And in this group, really, you want to think about environmental safety. So it's very important to really do these things. Probably a good idea to have a handout. I think we might have one in our file. First, we have these in our filing cabinet. But locking exterior doors, if it's a kid, upstairs, putting a child gate on the stairs. Padding the furniture, so if there's sharp edges in the bedroom, putting some padding on that. Heavy drapes on the curtains. I know patients that have walked through windows or glass doors doing this. Having alarms in the bed or the door, that would be a little bit annoying. You can imagine the bathroom is going to go off. But in some cases, maybe reasonable if this is a real problem. Sleeping downstairs, lock up the guns and knives, knobs off the stove. It's a real problem, particularly for shred, and then hiding the car keys. That's been part of their behavior. Under a rock somewhere. So treatment, again, sort of common sense things, safety, avoiding precipitating factors. If there's comorbid sleep conditions, treat those. So sleep apnea. I've actually had a couple cases over the years where patients have this sort of manifestation and got on CPAP and about resolved. Anticipatory awakenings, psychotherapy or hypnosis have also been recommended. And then the general treatment by the experts is benzos, particularly clonazepam, with these other ones as well. There's some small case reports of case series of other drugs. I'm not really sure how effective they are. Paroxetine and melatonin could be consideration if patients don't want to take benzos if they are going to be medications. All right, do you guys know about this thing? So sleep terrors, night terrors. You guys know this painting? It's green, yeah. So this is by Edvard Munch. He's a Norwegian. Supposedly, he painted this after going out one night at sunset, and there's like a blood orange sky, and he kind of freaked out. Nature's. He thought he felt the nature's screams. I think the real story is that he saw his kid waking up in a sleep chair. So my son used to have these when he was real little, and they're just, it's what it looks like this. They're very like this kid. They're just screaming, piercing out in the middle of the night. They're inconsolable. They're totally unaware of what's going on. This is sleep terrors. So again, sudden arousal from N3, piercing cry, signs of acute terror. They typically sit up, very anxious, disoriented. They're in the event. We used to try to console our son. Eventually, we just eventually go away and just fall back to sleep. This is what it's like, 2, 3. They can last up to 5 minutes, so it can be very distressing watching. 1 to 6% of kids, peak ages under 12. 2% of adults can have this. There's been a strong genetic influence. Again, meaning all the criteria for non-REM disorders of arousal, but then you have this typical behavior, abrupt terror, screaming. And these patients will have, or these kids will have the autonomic arousal. So their eyes are dilated, their heart's pounding, they're breathing fast, these sort of things, and maybe sweating. You have to differentiate this from nightmares, just general confusional arousals, which don't have those features. And sleep apnea is usually malingering. Precipitated, same sort of list of things. Differentiating from nightmares, which is a REM disorder, sounds like it could be a little difficult, but actually, when you look at a lot of the factors, there is pretty clear distinction. Again, timing, so sleep terrors are REM3, first part of the night. REM is going to occur later, that's when your nightmares tend to occur. They tend to move, nightmares do not. This is more severe. Patients wake up from nightmares are usually not a hyper-responsive state, but they can be. More common to have vocalization, sleep terrors, the autonomic tone is severe. They don't recall this, nightmares, they will recall problem with nightmares. Again, confused, disoriented, they wake up and they're functional, they're not confused, they know what's going on. Injury, violence, and displacement all can occur with sleep terrors where they're pretty uncommon with nightmares. So just by these historical factors, if for some reason you make it important that you have an absolute diagnosis, or it's going to change your management, you can consider a sleep study in these patients. A lot of times it's just history sort of this happens. So similar sort of things again, precipitating factors, get sleep hygiene, sleep deprivation, sleep schedule, for awakenings, hypnosis, reassurance. Most kids are going to grow out of this. It's not that common in adults and really other adults. Low dose benzos, and then again, for Dr. Schenk and his colleagues, a number of other things that could be considered trial evidence. So most of the time you don't need to do these things with reassurance of parents if confusion is dealt with. So this got moved in with ICSD-3. This got moved into the non-REM parasomnia. We realized this was an issue of disorder of arousal with further research. So the sleep-related eating disorder. It used to be in a different section. So this is preparation, consumption of edible, often high caloric or non-edible substances while asleep. So typically what this is recurrent involuntary eating, drinking during arousals from sleep with consequence. So patients are not aware or awake that they're doing this. They may find out about it in the morning, and they have food stains on their pajamas or the kitchen's messed up, like that, or something, that sort of thing. So it occurs during partial arousal. So again, the deeper brainstem areas of CPGs are functioning basic behaviors, but their cortex is suppressed. And so they tend to eat, it's usually not going in and like eating ice cream, right, or something good, or making a sandwich. They tend to eat very odd foods. So it's things like going in and just taking some mustard, eating raw bacon, weird things like that. They may eat things that are not edible, which can be problematic, lead to some of the consequences. Or they may eat foods that they're actually allergic to. If you have someone who has a nut allergy, probably shouldn't have nuts in the house, but maybe eat some nuts or something. It can lead to problems with insomnia because they can wake up with indigestion, reflux, disrupted sleep, and then their sleep is often not restorative, so they feel crappy during the daytime when they awaken. And they can actually have sleep-related injuries, so from just the whole process, they may turn on the stove and try and cook things, so you get burns related to that. You can get injury to dentition from eating things that they shouldn't be eating, something hard, so things kind of up on that. And then it can actually, because they're eating in the middle of the night, they're not brushing their teeth after this, right? So you can personally get a high gain. And then it actually can lead to weight gain, surprisingly. So these patients can put on some significant pounds of just like food in the middle of the night, not a way of actually doing this. So it's not really known how common this is. If you look at sleep or eating disorder groups, so in outpatient groups, it's around 8 to 9% will report this. If you look at inpatient sleep disorder groups or sleep eating disorder groups, it's around 50 to 70% will report this. And then when they've done surveys of unselected college students, it's around 5%. Most of them are women, about 60 to 80%. There's often an overlap with daytime sleep or eating disorders, bulimia, anorexia, but not always. And so the diagnostic criteria are, again, they're going to be usually criteria of arousal, but then they have recurrent episodes of dysfunctional eating. At least one of them must include eating peculiar or inedible foods or toxic substances, injury or potential injury due to this, and adverse health consequences. They're not aware, and it's not explained better as something. So you'll see a lot of patients. I have a lot of patients say they get up and wait in the middle of the night. Most of them don't have this, because most of the patients are aware they're doing this. There is also this condition of night eating syndrome. So some patients may wake up in the middle of the night. This is more classically between your last meal and you go to bed, having kind of hyperphagia, so eating a lot of calories during that time. We all know now, because you know, eating before bedtime is bad for multiple reasons. You know, and cause problems with insulin and melatonin and weight gain. But in this condition, they're awake, they're cognizant of what they're doing, which is maybe uncontrolled behavior. They can consume up to 50% of calories during this time. That is different from SRED, which is where they're totally unaware that they're doing this, and they're not going to the kitchen and cooking brownies out or something like that. So that needs to be differentiated. Like I said, I've seen a lot of patients who have this sort of problem where they eat too much in their bedtime and they wake up in the middle of the night, they're awake and they're aware and they're hungry and they're eat. That's different. It can also be driven by hypoglycemia, ulcer disease, reflux, plain loving, and seizures are part of the differential factors. Again, commonly associated odor disorders, particularly restless legs. So apparently, when they've looked at this, something like the 40–50% of patients who have this are report restless legs, and if you ask restless legs patients, a significant percent of them, smaller number, I can't remember exactly. And that's important because treating the restless legs actually can help reduce this. But also can be precipitated by other things, just like you think about with disorders of the mind. So kind of things can rush sleep, PLMs, OSA, certain medications, particularly some of the heavier sedatives can lead to this. So Ambien is another classic one. Treatment of this, again, I think about locking cabinets and drawers, and I know some cases people put locks on fridges at night, so they lock it up so they can't get down a bunch of ketchup. Treat comorbid sleep conditions, hypnosis, then the medications. SSRIs and topiramate are mentioned as treatments, and the dopaminergic agonists, particularly that restless legs. And not so much, they don't talk about the benzos for this. All right, so we'll move on to disorders of REM sleep now. And again, I'm not going to finish this all in 5 minutes, so people need to jump off. Maybe we should stop for a second to see what's in the chat. Okay, we got that. Good morning. Good morning. So danger to the person, to waking the person who is sleepwalking. The danger mainly can occur in that situation from trying to awake the person and redirect them. And I think it's sort of a case-by-case basis. But some people recommend not trying to do that because a patient can get defensive and violent, and that can be dangerous. So it's probably better to do the other safety maneuvers. Sleep enuresis, that is at the end. That's not considered a disorder of arousal. We'll come to that. So if you're still on, that's one of the last things we'll talk about in the miscellaneous category. All right, so parasomnia is in REM sleep. So this is really breaks out into three categories, which the biggest one you're probably going to deal with is REM behavior disorder, REM sleep behavior disorder. Recurrent isolated sleep paralysis occurs, but it's usually not such a big deal. It's mostly to reassure patients and differentiate it from narcolepsy. And then nightmare disorder, which you will see quickly, you'll probably see more of that at the VA. I've rarely seen this in my career. Sorry, it's kind of a little bit controversial. So REM behavior disorder is something that I've seen a number of cases of. I think it's probably underreported, and prevalence is probably higher than what we suspect. And maybe on the rise. I'm not sure. There's no data supporting that. That's been my sort of sense, or maybe we're just recognizing it more. So this is where patients lose the skeletal muscle atonia that occurs during REM sleep, and as a result of that, they do tend to act out their dreams as elaborate motor activity. Behavior is often violent, so it's often kicking, punching, pushing, running. I remember. So a fascinating case here. This was probably about 15, 16 years ago. A guy was admitted to trauma. He got up out of bed and ran into a brick wall in his bedroom. He ran head first and broke his neck. So that kind of solved his REM behavior disorder problem because he's not going to get up and run. He wasn't a full quadriplegic, but partially paralyzed as a result of it. So it hadn't been recognized before. It kind of been, I think, blown off as PTSD. So it wasn't recognized as he had so it can result in injury to the patient, obviously, and I'll show you a couple of videos for obviously I guess can occur if they don't get out of bed. Actually, one of my patients reported something just like one of these patients does, and there usually is very strong dream recall. So isomorphism is like sort of mirroring reality of what they're recalling. There's usually common themes these patients often report. So the dreams are very similar, actually. So it's often being attacked by animals. It's often running away or being chased by someone. It's not usually a specific person. It's nightmares. It's often reliving some experience that may be related to a person or event. These things are usually more vague in terms of the content, but it's very lucid in terms of what's happening. And they're expressing fear and not anger. It's not that they're usually trying to protect themselves or someone else. So some differentiating features here for some of the disorders of arousal. The eyes are usually closed. They do not walk. These patients might get up and walk along like a sleepwalker might do. Leaving the room is uncommon. Most times to be in bed, or they can do something right in the immediate vicinity. And then they don't tend to get up, eat or drink. There's no sexual behavior associated with this, and then they don't have false bladder, which you might see with a sleeper. Usually these patients in the personality, there's nothing in their personality that's predictive of this. So usually it's actually the opposite. Most of the patients are very calm, kind of mellow, open-eyed people, and they're just doing this bizarre behavior in their sleep. It's often associated with PLMs, very common. So let's see if this one works. This guy's sleeping. There's his wife next to him. You can see how that would be very painful. So patients can break bones, severe injury. Patient I have actually an older woman who's developed this. She was doing something similar. She would get up and knock over the night table. Whoops, that's the wrong one. The guy asleep in the sleep. So he was trying to kick something very violently. Can be confused for PLMs, but doesn't kill us. But there's no way we're just looking at it. So again, it's this state of dissociation between wake and sleep, particularly dream sleep. So it's thought to be an admixture of these two states of being. So in these cases, there's lesions in this sublateral dorsal nucleus, which usually is part of the process that inhibits motor activity. So when this is lost, you lose this inhibition, so skeletal muscle. So normally during dream sleep, you guys know it's your eyes and the diaphragm that are still working, but now in these cases, patients activity in the skeletal muscle. Majority of the cases are idiopathic. The remainder are associated with narcolepsy, so it's interesting data related to that. Then strokes, Parkinson's, multiple sclerosis, dementia, brainstem neoplasms, and medications are all things that can be associated with, particularly like SSRIs and other antidepressants. Again, there's no associated psychopathology. So narcolepsy is kind of interesting. Wasn't really aware of this, and I'm going to have to ask some more of my patients about this. But usually, so patients that are less than 40 have symptoms suggesting RBD. We find that it's almost always like either medications or narcolepsy. It's rarely related to the neurodegenerative process, which is the other big problem. So supposedly in the literature, I wasn't really aware of this, 50% of patients with type 1 narcolepsy have RBD. However, these patients don't go on to develop neurodegenerative disease. So it's just part of the manifestation of their sort of narcolepsy. I haven't seen that personally. But I've seen probably 1 or 2 patients, but I'll have to ask other patients about this. If you look at RBD cases, 13% of them, this is a case series, had narcolepsy. So the other big problem is the synucleinopathy, so Parkinson's, dementia, Lewy body disease, and multiple system atrophy. They have a common pathological lesion with insoluble alpha-synuclein protein in the pontine nucleus that controls sleep. It causes a lesion in that area, which then leads to the loss of motor control during sleep. So other less common things, so pontine, like strokes in the pontine area in that particular nucleus, demyelinating disorders, brain stem tumors, and then trauma. And then there's a list of medications, so SSRIs, SNRIs, TCAs can be precipitating factors. If you stop these drugs, they often symptoms go away, and these patients don't have this for problems. Rarely some other things. So it's now thought really idiopathic RBD is probably a prodrome syndrome for the alpha-synuclein neurodegeneration in the majority of the patients. It's confirmed it's actually one of the strongest early predictors of Parkinson's disease. So up to 50 to 70% is probably higher. So as we're finding out more about this, with idiopathic RBD, we'll eventually develop one of these problems, particularly Parkinson's, dementia, or MSA. And if you look at patients that have these conditions and look to see how many actually have RBD, the rates are quite high. So 30, 50% Parkinson's, up to 89% of MSA patients, and dementia, 80% will have RBD. This was a large case series, 1,300 patients, was published a few years ago. If they're disease-free from Parkinson's or dementia Lewy body, they follow these patients over 14 years. And you can see that by the end of the study, 80% of them have developed, of those surviving, still alive, have developed Parkinson's, dementia. So quite common, and the mean latency is thought to be from the onset of symptoms up to about 5 to 8 years. So again, it's thought to be relatively common, 0.4 to 1%, but if you look at particularly older adults, it's a little higher, 2%. I've seen a run of these patients recently. I got a number of patients with this condition. Predominantly males, 9 to 1, but again, thought to probably underreported in females, in part because they don't, a lot of times as you get older, you don't know the head part of the really, and just may not be. You do need to differentiate it from these other conditions, other confusional or disorders of arousal, seizures, PTSD, dissociative psych disorders, nightmares. Should also consider underlying things. So there's actually there's a case series of patients with OSA who manifested with like RBD, and it's just a mimicker. They're doing activities that look like RBD, history somewhat convincing. Sleep study that OSA, treat OSA, and behaviors go away. There's actually for like 25 patients or something. So all these things need to be considered in your differential diagnosis. So again, so the criteria repeated episodes of sleep-related vocalizations, patients usually often will yell out, complex motor behaviors, documented by PSG, or based on a clinical history of dream enactment or presumed occurred during dream sleep. It's probably best for most of these patients to get a sleep study to verify it. Sometimes the history is very classic, and in the right setting, the right patient population, comorbid conditions, to diagnose it, presumably without a PSG. But my practice has been the sleep study. You do want to see on the sleep study, REM sleep diatonia. I'll show you what that is. That's in the score in the end. It's right here. So there's two ways this can manifest. So one is the tonic activity. So at least half of an epic has to have chin EMG more than 2 times that of the background. And you can, it doesn't need to be continuous or sustained throughout. It doesn't need like 20 seconds or 30 second epic like that. Continuously, it can be in segments. So you can have at least 5 second segments. So you can have 5 seconds here, 10 seconds later. And then if it adds up more than 15 seconds, then that would be enough to score that epic as being tonic activity. You can also have excessive transient muscle activity. It's phasic. So these are brief little kind of spikes. This can occur in the chin or the EMG leads, oftentimes you see this in the legs. When we do sleep studies for these patients, we always do upper extremity and lower extremity EMGs. So you ask for extra limb leads. And then you should do, if possible, do the full EMG montage and see what when they're phasic, they tend to be very brief bursts, and they need to, again, be up to 2 times that of the REM atonia during REM sleep. So you can score an index off this, and there's criteria for that, but you don't need to necessarily report that, or it's not part of the diagnostic criteria that's at present, but there's a big research group looking at all this stuff, and they're probably going to part of that criteria eventually. You got to be careful though. So EMG activity, you can't see PLMs in REM sleep. Those are going to look a little different, so you want to make sure you don't miss that. But the other thing that can be confusing is sometimes you can see this tonic activity, you can be snoring, you should look in the chin, even REM sleep. So you want to make sure if you're getting like these bursts of activity, make sure you look at the respiratory parameters first, the snoring channel, make sure that's not. Sometimes we get mimickers, just like that. This is just an example of sort of that phasic activity. This is a leg EMG, and you see these kind of spikes going on here. So you're actually supposed to, I mentioned, break these out into mini epics at 3 seconds. So every 3 second little John is a mini epic, and then if more than 50% of those mini epics have this phasic activity, then it will count as that epic of sleep as REM sleep pattern. This one, that was from what I had seen before. This one I hadn't seen, but so this is looking. One of the other things you have to be careful. So you got to be careful. Snoring, the legs, chin, and then also your filter. Make sure that the chin EMG leads are attached. Right? So if they're not attached very well, so sometimes you may have to swap around the chin leads to make sure you're getting an accurate signal. Which ones you're linking up. You usually have 3. But if you have a poorly attached lead, it can look like it's chronically elevated levels. But in this case, supposedly this is accurate. So this is in the chin here, high tonic activity throughout. In this case, but you also notice patients having a lot of respiratory events and had sleep apnea. So this was thought to be a mimicker. They put the patient on CPAP, and now you can see the chin EMG is going flat with control of the sleep apnea. These variability down here probably just variable respirations related to the eye movement. So again, this can carry significant medical legal ramifications. Unfortunately, while majority of patients will develop neurodegenerative, not all will. So medical legal ramifications come from injuring themselves and from bed partners, that sort of thing. Again, not all are going to develop neurodegenerative. So informing the patient is probably appropriate, but you should do this. And it used to be whether you should tell them at all. Now I think most people are sort of on the same page. Patients need to know about this as a potential risk. But how you tell them, when you tell them, and the manner in which you tell them, if you spread it out over time, might be reasonable. It probably depends on the specific to the case and the patient, what the symptoms are, et cetera. So a referral to neurology is certainly very reasonable, particularly early on. If these patients have any signs of cognitive dysfunction starting to set in with show up on exam. So what's advocated as first-line therapy is melatonin right now. I remember I was at one of the ASM meetings and came up, this guy is a German guy who brought it up and I was like, what? Like, no way. I thought he was full of it. He presented a couple of case series and said there's a bunch of published things about putting patients on melatonin. He wasn't sure why it was working. He thought maybe it had to do with resetting the circadian cycle. But it had some impact, but it's since been studied and it can be effective, although it's not panacea. It's not 100% effective. The benefit to it is generally fairly well tolerated. So it augments REM sleep atonium, does improve symptoms, at least partially. So a lot of patients have a partial response. 3 milligrams at bedtime, that is not 6 to 302 milligrams. It should go up to 30. So some of these patients need very, very high doses. So often it's not uncommon about 20 milligrams, 25, and even up to 30 milligrams of this. Of course, the problem is making sure it's a quality approved, checked melatonin prescription. And then you have to watch for side effects. So a lot of these patients are older, where side effects may become more pronounced. So, dizziness could be daytime somnolence. You have to be worried about these things. But that's reasonable to try up front for most people, and that's kind of what's advocated as first-line therapy. Second line is clonazepam. Mechanism of why this works isn't fully understood. The dosing range is usually in the kind of the more reasonable range. But again, you're worried, it's a benzo, often older patients, oversedation. It probably is more effective at controlling symptoms, but the side effect profile is very different. So that's usually the next go-to, and there are some studies looking at using both these. Now I just found, it was last night or this morning, there was actually just a recent review on all this stuff, and it really suggested that the data is not very good in terms of supporting. Most of these have been very small studies, case series, limited data, and typical call for more research in this area. There's been a bunch of other drugs, including drugs thought to prevent neurocognitive or neurodegenerative disease that have been tried. Most of these things are in limited reports of case series. So there's a long list of things, so these could be considered backups to try on a case-by-case basis. There also is this, and I wasn't aware of this till not that long ago. I found this looking online. There's this group, this NAPS RBD group. So if you go to their website, you can actually see there's like 10 centers. So it's sort of like ArtsNet group, an RBD network that's conducting research in these areas. So they're enrolling patients. There's none really close by here. There's University of Minnesota, Mayo, WashU, Emory, Mass General, of course, Montreal, a couple on the West Coast. But they are the ones conducting a lot of these trials, trying to figure out how we can affect this and hopefully prevent progression or neurodegenerative disease. Interesting, there is data to, for like using some of the Parkinson's drugs, trying to implement those early on, it's just that, they're not actually that effective at controlling symptoms. All right, so RBD, so you guys will see that for sure. And then recurrent isolated sleep paralysis, also known as hypnagogic paralysis. So probably finish up in about 10 minutes here. So it's inability to perform voluntary movements at sleep onset or awakening. So this is an intrusion of REM atonium in the wakefulness. You guys ever had this? I used to get this when I was in med school. You have a few times I take, a test would coming up, I'd be going to sleep and I'd take a nap, and I trying to wake up from a nap. And it's terrifying. You feel like you're awake, you're kind of aware of what's going on around you, but you can't move anything. And the worst thing is it starts to feel like it's ascending, but you can't breathe. And it can actually go on for a while. So your the limb, trunk, head movements are not possible, but you can move your eyes and you can breathe. Again, your sensorium is intact. It can be frightening. So sometimes this can actually occur if you feel like there's a presence in the room or in the next room, or somebody's in the house or something like that. So that's been reported. It can last up to several minutes. It can be terminated easily. It'd be hard to know if someone's in it, touching or noise. So it can be isolated. So again, it's not that uncommon in younger individuals. And the lifetime prevalence is up to 40 to 50%. So a lot of people will experience this. It can also be familial, and it can be related to narcolepsy, obviously, sleep paralysis. So we got to ask detailed questions to make sure. Usually as we get into young adulthood, that's what I have in mind. Precipitating factors: alcohol, regular sleep habits, like studying for exams, sleep deprivation, and stress. The ICD criteria: so recurrent inability to move the trunk or limbs, sleep onset or awakening, seconds to minutes, causes distress, you can get anxiety about going to bed, not explained by other things. Narcolepsy is the biggest thing in differential diagnosis. A list of other things to consider: hypotonic periodic paralysis. I saw that. I've seen one case of that when I was a resident. It presented differently. Treatment: just make sure they don't have narcolepsy. You don't need a sleep study on them again unless you have other supporting features. Usually reassurance: avoid precipitating factors, enough sleep, or stressors, regular sleep schedule. There's reports of using some of these drugs, clomifene and different Prozac, trying to reduce this. It's probably similar to what it does with narcolepsy in terms of cataplexy. All right, Chuck, we're just having a nightmare. So nightmare disorder, dream anxiety attacks, either frightening dreams awaken the sleeper from REM sleep. They're long, complicated, increasingly frightening, anxiety-provoking. Talking, screaming, striking out, walking is rare. So these patients do not manifest these things overtly. So that differentiates it from sleep terrors, from ODD, sleepwalking, all this. Up to 75% of kids will have these at one point, at least one. Tend to decrease over age, but you can still see them as we get older in the elderly. Some predisposing factors, like the long list of other things: stress, trauma, certain medications, particularly the beta blockers, statins. Chantix is one of the newest, greatest ones. And then some personality disorders can predispose to having nightmares. If you're concerned there's something else going on, or you really want to confirm the diagnosis, you can't do a sleep study. It's not part of diagnosis criteria. And that's going to classically show abrupt arousals from REM sleep associated with that autonomic kind of response, and then the patients will report what's going on. So it's kind of a combination of video PSG and detecting in that talking to the patient. Criteria a little bit long. So description of the dreams, dysphoric, and then the dream experience must lead to some sort of consequence. So mood disturbance, sleep resistance, cognitive impairment, negative impact on the caregiver family. So if they're having a lot of nocturnal disruption resulting from this, sleepiness, fatigue, impaired occupation or personal skills, those sort of things. So there need to be some sort of, can't just be they have bad dreams. They have some consequence to having bad dreams, which a lot of these patients go through. Similar differential diagnosis we've talked about already. Most kids are going to outgrow this. It's not going to be a problem, but there are small number which persist with unclear outcomes. If there's an offending agent, switching up drugs can be beneficial if you think that's the problem. Again, sleep disorders, treating stress. So prednisone has sort of been the standby drug, although there was a study, I think it came in, correct me, because you guys probably deal with this a lot at the VA, but I think it was a VA population that looked for some post-PTSD patients and found it was not very effective. So there was a large randomized study. Prior to that, there had been smaller, some randomized, some just observational studies suggesting there was a benefit. That's kind of in the 13th row. It's a blocks the alpha-1 receptors, and so it's thought that that may be how it works. There's less data, limited data on trazodone, and may work for PTSD concomitant with some. What's really probably maybe the best therapy for this was something that was pioneered by one of my mentors, Barry Krika, did a lot of work with this, is image reversal therapy. So this is actually organized, structured program where patients are taught to sort of, so these dreams are often recurrent, so they're vivid, they're lucid, they remember them, they're often related to specific events. They often are repetitive, so that they have the same dreams over and over, plane crash, car accident, whatever. is to actually have the patient with journal the dreams, and then you start working with them on changing the dreams. So writing out, changing the outcomes to get better, more favorable outcomes. And actually, in good studies, so it's from Dr. Carter here, extensive data and research show that it's actually quite effective with very limited side effects. So if you don't do it correctly, it can lead to worsening of dreams. But right, somebody who's been trained in doing this, it can be very effective. It can be used to treat both idiopathic and PTSD-related dreams. Basically, they're changing it to how the patient wants for a better outcome. A little bit similar to this, there's other psychotherapy approaches, including lucid dreaming therapy, in which they learn to change the dream. Somehow they're taught, and I think this is through meditation and sort of feedback about how to change, to try and work within their dreams to change it. So it's different from just doing this while they're awake. And then there's also desensitization therapies that can be used and write down, they relive it until during the day, using imagination and sort of desensitizing them to the dream. These are really kind of the realm of sleep behavioral specialists, so we're not good sleep behavioral specialists. So you should know if you refer these patients, unless you're behavioral sleep medicine trained, I wouldn't be expected sleep specialist. All right, last few. So this is getting to the miscellaneous category. So those are we did the non-REM, we did the REM. There's a few, only 3 miscellaneous ones. So exploding head syndrome. I don't think I've ever seen a case of this. Does have tendency to show up on boards. I'll tell you that. This is sudden noise or sense of explosion in the head, the wake-sleep transition, or upon awakening. The most commonly it's when patients are dozing off. It's abrupt arousal, for instance, a sense of fright with this, so someone wakes them up. It's different from a hypnic jerk, which is just sort of body spasm, and sensation of falling. This is like something goes off in the head and you wake up. We don't really know why this happens. It's not very common. There may be a hallucination happening when you're falling asleep. Generally, it's reassurance. These things, when patients do have these, it's not like a nightly occurrence. They're pretty uncommon. Oftentimes, you reassure them, let them know it's nothing serious or concerning. They can go away on its own. In some cases, again, these are small case reports, case series, using a variety of different medications for these things, non-iodine, etc. Sleep-related hallucinations, so like sleep-related paralysis can overlap with narcolepsy, so that's the biggest thing to well. These things is waking up, falling asleep, having some sort of active dream that's going on as you're waking up, falling asleep. So it's a crossover between REM and wake time. Again, more common in youth. It can be also be associated with drug use or withdrawal, alcohol use or withdrawal, anxiety, mood disorders, insomnia. Same sort of differential we talked about already. The biggest thing you realize is narcolepsy in these cases. You diagnose it based on history. You do not need a full sleep study. And then usually it's just reassurance and sleep hygiene. They don't need medical therapy. And the last one, sleep-related enuresis. So this is diagnosed when kids are older than 5, recurrent involuntary voiding during sleep at least 2 nights a week, and it has to go on for 3 months in order to be diagnosed. Primary is where kid was a bedwetter the whole time, and then now they're over 5 years old, it's still going on. Secondary is where they actually were dry for a period, I think at least 6 months. So they've been bedwetting a little, they're no longer a bedwetter, and now they're bedwetter. So in that situation, you also need to rule out a number of secondary things, like excessive water intake, some medications, the parasomnia could be associated with seizures, all those sort of things need to be thought about and ruled out. They don't need a sleep study though, unless you have a high suspicion for something else. Prematurely fluid restriction, bedwetting alarms can be very effective. Some cases, again, not a lot of great data, desmopressin, and then treating underlying causes. All right, and I think that is it. This is actually a very interesting book. You guys have ever read this? I read this a long time ago. Acceptable Risk. It's about the Salem witch trials. There were reports that the girls that were, calling everybody witches were eating dry bread and maybe hallucinating and stuff. And so he sort of took this into a fictional mode, and the scientists, researchers found there's some mold that causes this. And what happens is if the researchers wanted to get this thing rapidly advanced and treat it, they're also during the day made him feel calm, gave him a strong sense of confidence, all that sort of stuff. But it turns out at night, it was probably parasomnia, getting up and going out and doing all sorts of bad things, including killing people. I won't tell you how it ends, but it's a parasomnia related, but it's actually a good read. It's kind of fun. It overlaps with sleep medicine. All right.